Great. Well, my name's Wendy Fenton, and I'm the coordinator at the Humanitarian Practice Network here at ODI, and I'd like to welcome you all to today's event and also the online audience. Today we're focusing on improving mental health and psychosocial support in humanitarian crises. And as I'm sure you all know, humanitarian agencies are increasingly prioritizing the provision of mental health and psychosocial support for people affected by crises. And this is really an important and welcome development, especially given that according to the World Health Organization, the prevalence of mild and moderate mental disorders can increase from a baseline of 10% to an estimated 15 to 20% in humanitarian crises. And at the same time, unrest and conflict can exacerbate the challenges in actually delivering high-quality mental health and psychosocial support. For example, in the Central African Republic, instability in the presence of armed groups means that people have to travel much further to try to access care. And in many cases, they simply can't get that care that they need. In Iraq, about 20% of the population will suffer mental health problems at some point in their lives, but only 6% are able to access the support that they need. So today, drawing on articles from the latest edition of the Humanitarian Exchange, and I think you have copies of this on your chairs, and their own research and experience, our panelists are going to reflect on the progress made in strengthening the evidence base on effective mental health and psychosocial support approaches in humanitarian contexts, and importantly, also on translating those into good practice on the ground. We're also going to discuss some of the challenges faced in both researching and implementing these approaches and interventions, and some strategies for how to address those challenges too. And I think another issue that will come up too is the very fruitful partnerships that are being promoted between academic researchers and humanitarian practitioners as well. So I'd now like to introduce our panelists. On my right, starting on my right, is Noor Kik. Noor is a public health professional and currently the Policy and Advocacy Coordinator at the National Mental Health Program in the Ministry of Public Health in Lebanon. And she's leading the coordination of the Mental Health and Psychosocial Support Task Force, which aims at ensuring an effective, coordinated, and focused interagency response to the mental health and psychosocial support needs of persons living in Lebanon, with a special focus on persons affected by the Syrian crisis. And she also coordinates the development process of mental health-related strategies and plans and efforts to mainstream mental health policy in other sectors. Noor has traveled from Beirut as well to be with us today, especially. So welcome, Noor.
Thank you very much.
And then joining us by video conference from, I think, the US is Natalia. Do we have Natalia on the screen? Yes.
Yes, hello.
Hi, Natalia. Natalia Kostandova is a program coordinator with the International Medical Corps in Central African Republic. And Natalia has over 5 years of experience working on health programs in Burkina Faso, Tanzania, Chad, and CAR. And IMC has been implementing mental health and psychosocial support programs there since 2015. And the IMC program in CAR focuses on working with healthcare providers and provision of emergency relief and protection services. Then on my left is Dr. Allison Schaefer, who is trained in clinical psychology. She completed her PhD research dissertation in South Sudan, which is an area that I've spent quite a lot of time in and on, exploring various elements of mental health and psychosocial support. And Allison's currently a technical officer in the Department of Mental Health and Substance Abuse at the World Health Organization. I think you're based in Geneva?
Yes.
Yes. Having spent the previous 8 years as the global, can I use this acronym? MHPSS, Mental Health and Psychosocial Support. It's a terrible one, actually. Technical advisor for World Vision International and World Vision Australia. And when she was with World Vision, Allison was part of the responses to the Ebola crisis in Sierra Leone, the Syria conflict, and in the occupied Palestinian territories of West Bank and Gaza. And then last but not least, we have Dr. Wietse Toll joining us from Denmark. Hi, Wietse. Can you hear us? Ah, you must be on mute. Wietse is an associate professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health, and also director of the Peter C. Alderman Program for Global Mental Health at HealthRight International. Wietze's research and practice focuses on mental health and psychosocial support in humanitarian crises. And he's particularly interested in integrated programs that address the social determinants of mental health with people who experience adversity. And before we actually start our discussion with the panelists, I'd also like to introduce Ann Harmer, who is the program director for ELRA's Research for Health and Humanitarian Crises program, and my co-editor for this edition. And Ann's been a huge support on this edition and really really shaped it, I think, in terms of the direction it went in. And I'd like to give Ann the opportunity just to say a few words about ELRA and the R2HC before we start.
Okay, well, thanks, Wendy. For those of you who don't know ELRA, we're an NGO that supports partnerships, research, and innovation to improve humanitarian outcomes. And we have two large substantive programs, one that's the Humanitarian Innovation Fund, and the other one's the Research for Health in Humanitarian Crises program. And we fund quality innovation and research through a range of diverse actors and partners in order to get the results, which we then use. We synthesize the outputs of the work that we produce, and we develop guidance and tools to actually support the practitioner communities. And the R2HC program itself is our objective is to improve health outcomes through increasing the evidence base on public health in humanitarian crises. And we were established in 2013, funded by Diffid and the Wellcome Trust, and now working also with the Department of Health. And what we aim to do is actually to increase the evidence base through the funding of research. And every research program that we support has to have an academic researcher working alongside a humanitarian practitioner in order to make sure that the research that we fund actually improves and feeds into policy and ideally practice. So a lot of the work that we do then is around advocating with key stakeholders and influences in order to make sure that the research outputs feed into what's actually happening to improve practice. So last year we collaborated with WHO on a consultation with the MHS, the Mental Health and Psychosocial Interagency Reference Group, to actually share the initial findings of some of the research that we have funded, and also to look at how we can make sure that the research and the interventions that are successful can then be taken to be implemented successfully in the field. So that was a very interesting initiative that led us then and helped us, myself with Wendy, to actually identify a far larger network of people whom we were able to approach to be authors for this particular special edition. And of the 40 research programs that we've funded actually since we were established in 2013, 12 of these have focused on mental health, which is very exciting for us because it means that there's a substantive body of evidence that we can really start to take forward the collective ideas and solutions to move forward. And then of the 16 articles actually in this particular special edition, I'm really delighted that 7 of those are people who are actually collaborating directly through research with the R2HC program. So I really hope that this special edition is going to be of interest and use both to practitioners and others who are really seeking to make sure that what we do in terms of addressing the mental health of people in humanitarian crises is evidence-based and effective. So thank you very much, Wendy.
Thank you, Anne. Okay, let's move on now with I have a few questions that I'd like to ask our panelists. And Noor, I'm going to start with you. As you note in your article, the Syria refugee crisis has placed a huge strain on the Lebanese healthcare system. And the gaps in service provision and the lack of coordination between humanitarian actors was highlighted as early as 2013 by your colleague and co-author, Dr. Rabi El-Shameh. And in his report for UNHCR on mental health and psychosocial services for displaced persons, I mean, since then, how has the Lebanese government tried to address the issues around access to mental health care and coordination between the various actors?
Thank you, Wendy, for this question. Indeed, the Syrian crisis has placed an enormous strain on the Lebanese health system, with the population having increased by more than 1/3 since the onset of the Syrian crisis. This has had repercussions on the economy, employment, and basic needs, including health services, physical and mental health services. And this has also exacerbated, when we talk about mental health care, the limitations of the already weak mental health system in the country, even before the crisis. Because if we look at the system that was in place, we had the availability, the accessibility, and the affordability of mental health services was highly limited. We had mainly services that are focused on the specialized hospital-based care, available mostly in the private sector, so affordable to a few. We had no mental health department in the government, no mental health strategy, and no legislation that could protect persons with mental disorders. And this gap of services was highlighted in the report that you're mentioning, Wendy, that was conducted with the onset of the crisis. And the report, the results of the report actually were a triggering point, because building on that and recognizing that actually emergencies can be an opportunity to build back better, the Ministry of Public Health of Lebanon adopted a long-term vision to respond to these challenges and to build a sustainable mental health system in the country. So what it did actually is that it took key strategic steps to move towards this long-term vision. The first thing was that it established a national coordination mechanism for the MHPSS response, and took on its leadership. It also launched a national mental health program within the Ministry of Public Health to lead the mental health system reform. And in order to guide the reform, to have a roadmap, the program launched in 2015 the first national strategy for mental health for the country. The strategy covers the period of 2015-2020. It has the vision that all persons living in Lebanon will have the opportunity to enjoy the best possible mental health and well-being. And here I would like to stress on the first part of the vision, which is that all persons living in Lebanon will have this opportunity. Because actually that's the strategy, it aims to build a system in the country that can cater for the needs of both Lebanese and non-Lebanese living in the country, so as well displaced persons and refugees that have come to Lebanon, through ensuring increased availability and accessibility to mental health services. How do we aim to do so? Through achieving objectives that are set in the strategy in 5 domains of action. The first is leadership and governance. The second is service organization and scale up. The third is promotion and prevention. The fifth is information, evidence, and research. And the fifth is dedicated to vulnerable groups in the Lebanese context that need special attention when it comes to mental health. So basically, the response that the ministry has undertaken is based on a whole system approach, with the aim of building and anchoring all the building blocks of the system and ensuring that it is accessible to everyone. So since its launching, actually, the program has currently around 50 active projects to implement the strategy in collaboration with different partners, because the program relies on a collaborative model for implementing the strategy. Key features in terms of service development include developing services in line with the WHO pyramid of services, if you're familiar with it, which aims to increase accessibility to affordable, high-quality, evidence-based mental health care. So we are, in line with this, integrating mental health into primary health care, in line with the WHO MHGAP program. So basically building the capacity of general health professionals in primary healthcare centers to identify and manage persons with mental disorders. And the next layer, for more complex and severe cases that cannot be managed at the primary care level, we are establishing community-based mental health centers that can provide multidisciplinary care close to where people live in the community. And as part of the ministry's Universal Health Coverage Project, there will be packages of mental health services subsidized at the primary healthcare level in centers that cover areas that serve the most vulnerable populations in the country to increase accessibility to these services. In parallel, there are interventions being done at the level of improving the quality through accreditation standards, guidelines, monitoring mechanisms for human rights, building local capacity in evidence-based psychological interventions such as interpersonal therapy. I'm sure, Allison, you might touch upon this later on. And as I said, all these services that are being built and provided are accessible to all persons in the country. The fifth domain of action in the strategy is focused on vulnerable groups, as I mentioned before. And here we identify groups in the Lebanese context that are more prone to develop, that are at a higher risk to develop psychological distress and therefore need particular attention. And here we include displaced persons and refugees. And the objective at that level is to sustain the national coordination mechanism, which I mentioned earlier, the MHPSS task force, and to ensure we have an annual action plan to address emerging gaps and needs identified on the ground. The task force is chaired by the Ministry of Health and co-chaired by WHO and UNICEF. And as you see, this national coordination mechanism for the humanitarian response is actually anchored within the national policy framework. And the action plan of the task force supports in the implementation of the national mental health strategy and in addressing other specific gaps. So some of the achievements include, for example, developing normative contextualized guidelines, such as minimum recruitment criteria for professionals working in the humanitarian context in mental health programs, MHPSS indicators to monitor service utilization, but also some quality indicators in MHPSS programming as part of the humanitarian response, and also contributing in developing capacity in evidence-based interventions for mental health professionals, but also for professionals in other sectors, such as the protection sector. Basically, this whole the response in Lebanon is focused on a collaborative governance model where there is partnerships between the government and humanitarian actors in order to build and strengthen the national system.
Thank you, Noor. I mean, that sounds really interesting, and as if the influx of refugees and displaced persons, the crisis, provided an opportunity really to make some much needed changes in the systems. But also in dealing with the humanitarian actors in particular as partners. I mean, I suppose we could say that in many cases there's either a resistance to working with government sometimes, depending on the context, or definitely a difficulty in trying to coordinate. I mean, we say it's like herding cats. And so I just wondered, have there been any challenges that you could talk to us about, and what strategies have you used to address these?
So yeah, I couldn't agree more with you that coordination is very important and critical, but it also can be very challenging, especially in a context where there is a multiplicity of actors that come with a diversity of agendas, interventions, ways of working, accountability lines, and so on. So we have actually witnessed at some points in the national coordination mechanism a limited commitment of certain actors to engage with the work of the coordination mechanism and to support the implementation of its action plan. And this could be due to first of all, the fact that initially within the coordination mechanism, there weren't any specific membership criteria. So the actors participated, but did not have specific required commitments to work towards the action plan and support coordination. But also because of the humanitarian system, which oftentimes indirectly promotes a higher accountability upward to donors rather than to communities in certain contexts. But this challenge, we try to overcome it through, first of all, ensuring engagement of actors through membership criteria and higher commitment required to support the action plan, but also through promoting the collaborative governance model that I spoke upon earlier. And here there was a key step that was done by the Director General of the Ministry of Health, who issued actually a circular asking all actors, calling upon them to coordinate with the Ministry of Public Health whenever there are new projects in the field of mental health, to ensure that there's no duplication with activities done by other actors, and there is alignment with the national priorities set forward in the national roadmap for mental health. And this actually has proven to be highly effective, because it provides an opportunity for actors to contribute to the fulfillment of national goals, and it is an opportunity that gives mutual gains for everyone.
Thank you, Noor. I think we're going to move now to a very different context. We're going to move to the Central African Republic. And Natalia, I have a question for you. As we said earlier, the CAR has experienced decades of turmoil and instability. And it's marked by civil unrest and military coups and conflict. In the last 5 years in particular, have seen the development of an immense humanitarian crisis. I think there are almost 2 million people in need. What are some of the barriers to implementing an effective mental health integration program that builds the capacity of service providers to identify and treat mental health disorders in this type of context? Could you talk to us a little bit about that based on your experience?
Sure. Thank you very much for the question, Wendy.
I don't think we can hear you. Are you muted?
The opportunity.
Ah.
No, I'm not.
Okay, yeah, sorry, just repeat what you just said.
Sorry. Yes, I was telling you thank you for the question. And I was thanking the organizers as well as the panelists for the opportunity to have this discussion, because it is something that we see, unfortunately, fall through the cracks often in the implementation of humanitarian response. So I'm very pleased to be able to share some of the experience that we have had with International Medical Corps in Central African Republic. So as you had mentioned, we have programs, MHPSS programs, that are operating in a very constrained and challenging environment with huge levels of displacement and with a large swath of population that is having difficulties with access to services and just even providing their very basic needs. So with that regard, we currently have, to provide a little bit of context, International Medical Corps has been operating in the environment of Central African Republic since 2007. There we have been providing emergency response as well as support to the Ministry of Health in the areas of health, nutrition, protection, and WASH. The MHPSS programming has been in place since 2015, and this last 3 years really have shown a lot of challenges and has allowed us to have experience to build on for the future programming. So one of the biggest challenges that we have is actually figuring out how to begin, how to put in place an effective MHPSS program in that kind of humanitarian context where every day provides a different context. And we have seen with our experience in CAR, as well as in 14 other countries where International Medical Corps is currently providing MHPSS programming, that really the only way to properly assess the situation and effectively shape our program is to carry out a formal MHPSS assessment, because that allows us to assess the challenges that are there. And the challenges are very specific to the humanitarian context. As an example, we are currently operating in the Haute-Koto Prefecture, which is a hot zone of a conflict that had really ramped up in the last year. Over 80% of the population of Bria city has been displaced within the course of 2 weeks that the conflict had started. So in that context, figuring out how to set up a program has been challenging. Even understanding whether our MHPSS clients can access the health facilities, or whether we need to bring the program to them through mobile clinics or through actually having our specialists travel to the IDP sites, travel to the remote villages. That kind of understanding will allow us to either succeed or fail miserably. We can set up a perfect system, we can use all the guidelines that exist, but if the clients are unable to use services, then what are we actually doing? As an example, this assessment becomes very important because in a neighboring prefecture where we are preparing to set up another MHPSS program, the situation is very different. It is a neighboring prefecture. We have a lot of similar contexts. We have similar cultural composition. We have similar ethnicities. We have similar religious concerns. But in that prefecture, the clients are able to access services in the Bambari hospital. So we have to set up completely different programs, even though on the surface, these two areas look rather similar. So carrying out assessments in this kind of environment is a challenge because of insecurity, because of access issues, because of having to negotiate with armed groups, having to mobilize local authorities, and to get the community buy-in at the time of civil strife. That is the first challenge. And I would say that is one of the lessons that we can learn from that as well, is the need to carry out this kind of an assessment. Then the second challenge pertains exactly to building of the local capacity. And that is the second core area of the successful MHPSS integration. Building capacity in a humanitarian context is hard for many reasons. The first reason would just be actual presence of human resources on the ground, as well as all the way to the top. So on the ground, we can talk about prescribers and non-prescribers, people who are able to identify, refer, and manage MHPSS clients. In a period of conflict, you can imagine that we have a drain of resources that have been put in place. With 80% of people displaced, it is not just the potential clients that are being displaced. It is also healthcare providers. It is also difficult to bring in additional resources because people don't particularly want to go into this kind of area where there is instability, where there is a huge personal risk. Then it is difficult to actually organize any sort of trainings or any sort of capacity building exercises. As we've seen in Haute-Kouta Prefecture, we tried to set up a training in September of 2017, but we were not able to actually put it in place until March of 2018, simply because during that time, our participants were unable to come from their villages to the training location because the armed groups were controlling all of the roads. So taking all of those aspects into account and trying to remain flexible within the constraints, regulations, and our agreement has been a challenge. Being able to provide supervision to the trainees has been a very significant barrier as well. And here I want to give a little bit of context. In the way that we have set up the program, is that after initial training of prescribers, which are our nurses and our doctors, on providing care, on providing case management to the MHPSS clients, we have to be able to provide them with supervision. Within this supervision, our specialist, who is a clinical psychiatrist, first provides consultations himself, while the prescribers are shadowing him for a period of 1 month. Then after 1 month, we have a little bit of a switch. So now it is the trainees that are providing case management to the MHPSS clients under the direct supervision of the clinical specialist. This period has to last for at least 2 months in order to allow our trainees to receive the proper supervision, to receive the proper support, and for us to identify if there are any additional gaps in the technical knowledge of our trainees. Then after this 2-month period of supervision, we have to be able to continue supervision on a somewhat regular basis in order to provide continuous support. So as you can see, this is a time-intensive program, and I'm very happy that Noor as well had brought up the fact that you have to have a long-term vision, because MHPSS programming is not something that we can do within 6 months, within a year. This is something that has to be long-lasting, which is why we are emphasizing capacity building for local resources, but providing it in a context of instability where we have trained our providers and they had to flee due to insecurity, due to threats, where we have had healthcare providers that have been murdered by the armed groups, And having put that investment into the human resources, seeing them disperse, seeing them go into hiding for periods of time has been very challenging. As a final challenge, and that is also just finding the resources to invest in the human resources at the ground level, but also making sure that we have technical support in the headquarters. We normally do rely on our MHPSS advisor, who is able to provide us guidelines and guidance on making sure that the program that we are carrying out is consistent with international guidelines and standards. We have to have local coordination with the Ministry of Health. We have to have its resources available and their buy-in as well, because at the end of the day, we are not there to provide parallel programming. We are there to help support the ministry so that after intervention is over, it is able to take over and it is able to provide the services necessary for its own population. Making sure that all of our objectives and all of our interventions are aligned with the MOH and are aligned as well with the donor priorities. You?
Thank you very much, Natalia. I think you've really done a good job of outlining the challenges, and I think that all of us would find daunting. And it's clear that in addition to doing the initial assessment, it's really necessary to go in knowing that you're going to have to adapt your program at different points. So being able to be flexible and adaptable within that context is absolutely key, while still trying to do the best job that you possibly can. I'm actually going to move on now to Allison. And Allison, you co-wrote 2 articles, actually, for the Humanitarian Exchange, and one was focused on a 5-year retrospective study of the application of psychological first aid, or PFA, which is a bit easier to say than
MHPS.
Yeah, that one. And the other article was about potentially scalable psychological interventions. And I wondered if you could first elaborate on the differences between PFA and scalable psychological interventions, and what the study of PFA applications and the development of psychological interventions is actually telling us about both approaches.
With pleasure. So, in 2011, World Health Organization, World Vision International, and War Trauma Foundation published a guide called the Psychological First Aid Field Guide, and it was intended to be psychological first aid, or PFA, which is a basic response to a person who's recently experienced a traumatic event or are having a serious distress response to some emotional issue. And PFA could be relevant if you've been in a car accident. It could be relevant if you've just been displaced. It could be relevant if you are in an acute grieving process. It could be anything that affects any one of us in this room. And we've probably all provided each other at some point some kind of psychological first aid. And psychological first aid was always designed to be that first line response to distress. It's intended to keep people safe. It's intended to help restore their sense of dignity and to provide them a sense of support. What interestingly has happened is the Psychological First Aid Guide was so well received that it had massive it was a global phenomenon, and it went into the world. It's now been translated in more than 20 different languages. There's facilitation guidelines, and everybody does PFA. And one of the challenges that we've actually had is that a lot of people are saying we're covering mental health and psychosocial support because we're doing PFA. That's where people have probably fallen down in their understanding of what PFA is. In contrast, an actual psychological intervention, even what we would call a low intensity or a brief psychological intervention, is intended for someone with actual mental disorder. We may not need to know whether it's the difference between depression or anxiety or chronic or traumatic stress. We know that many of these scalable interventions have the potential to treat all of those things without a diagnosis. What the research is actually telling us is that there is a need for both of these things. So the Psychological First Aid Retrospective, which was led by one of the key authors of the original guide, myself and Church of Sweden, it really said that people wanted psychological first aid to stay as it was because it's scalable, it's easy for people to do, and it's tapping into that human nature that people want to be able to provide support. Mm-hmm. If you're upset, I'm able to provide you with some basic social support and help you get through this immediate time. But it is not a panacea, and it is certainly not a replacement for people with mental disorder and people who need more focused and specialised support. The scalable psychological interventions that are being developed by World Health Organization and many others in the field of MHPSS are trying to look at ways where we can get greater access to care for people with actual mental disorder. And so they're taking common elements and common aspects of well-known therapeutic strategies such as interpersonal therapy, self-help strategies, acceptance commitment therapy, cognitive behaviour therapy. They're taking the basic elements and the active elements of those things and putting them into a brief intervention that is manualised, and what's critical here is that it can be effectively delivered by non-specialist providers. So we can train community health volunteers. One intervention trains grandmothers to provide a problem-solving therapy. There are a number out there, but that's quite a different beast to what psychological first aid is. There is a need and there is room for both, but they cover a spectrum of MHPSS responses that are necessary in any emergency response. So I welcome the opportunity to distinguish them because they are really quite different. And there is a lot of research that probably still needs to go into both areas where we know now that we have these psychological interventions and that they're effective, but we have some challenges in relation to how we scale them up. With psychological first aid, we know that it's providing good support, and we know that it is a good, I was almost going to say intervention, it is a good action in the absence of other things and other supports at the time, but it is not a replacement for mental health care. And certainly the international guidelines for mental health and psychosocial support say that we need to have that whole spectrum of care, that whole building of community support, the inclusion of social and psychological considerations when we deliver basic needs, but we also need those specialised and focused supports, whether they're provided by professional psychologists or non-specialist providers.
Can you give us some examples of where psychological interventions have been successfully scaled up?
Yeah. It's an interesting question because one of the questions I pose back is, what do we actually imagine that scale is? Okay. When we test psychological interventions and do studies in the field, they're often reaching in the hundreds, 500, 600 people. There's kind of lacking evidence in the large scale, in the thousands area at this point in time. But ultimately, to make something scalable, we want it to reach more people at minimal cost and minimal resources. So perhaps not a humanitarian context, but certainly in Kenya, there's been some good examples of doing a trainer of trainer model and a cascading of one psychological intervention called Problem Management Plus, and that reached the thousands in about a 6-month period. There's another self-help intervention which Vitsa has been working on in Uganda that's showing some promising results, and that's reaching up to maybe 30 or 40 people at a time. So we're finding new platforms and new delivery approaches that can try to scale things up, but it's certainly an area that a lot of work still needs to be done in. We have a lot of hope also for technology-supported interventions because we think that that's going to, we know that there's an evidence base for their effectiveness. We've got to make them user-friendly for the context and the clients that will use them. So that's something certainly that World Health Organization and others are looking into more now.
And I think, the one important thing to emphasize is that you're looking to scale, or everyone's looking to scale up, evidence-based.
Yeah.
interventions.
So one of the challenges around that is we have to watch this careful balance between quantity and quality. So we know that there is a massive mental health care gap out there. We know that most people who need support, as Nora and Natalia have indicated, most people who need this kind of assistance are not getting access to it. So we want to try and focus on scaling it up and getting it to be more accessible. The challenge is when you scale things up, you then lose a little bit of control around how effectively and how much quality goes into how those things are delivered. And so that's something that we have to be very careful of and take a very measured approach. When you get to the point of doing psychological interventions, there is actually a risk of doing harm. And poor quality would not only be a waste of resources, but also a potential risk to people receiving support. So that's something that we need to find out how we do things to scale, including things like clinical supervision, which is very important in the process of delivering those interventions.
And just one last small question, or not question really, but I know that you make the distinction between evidence-based and evidence-informed. Could you just tell us a little bit about what that is?
Okay. In my mind, so evidence-informed is kind of where we look at all of the evidence in psychological papers and mental health treatment, and we know that there are some foundations and some good basics. I think one of the classic things for me is we know it's important for children to play. Yeah, I don't really need a whole randomised control trial to tell me that it's important for children to play. Mm-hmm. So I would say that coming from a statement that it's important for children to play is an evidence-informed perspective. I can't pick a randomised control trial, though I'm sure they exist, to actually say this is how children should play or this is the way children should play. But we know that it makes good sense. It's good common sense. And that's what psychological first aid is. Psychological first aid is evidence-informed. We don't actually have randomised control trials to say that it does X, Y, and Z. But we know that it's evidence-informed to provide people with safety, dignity, support, linking them to other services and ensuring that they're ready to take the next step and that we've got a sense of being able to help them feel calm and hopeful about their situation. In contrast, a psychological intervention is what we call evidence-based. It means that the intervention has gone under a randomised control trial. It's gone under very specific conditions and it's compared to what we call a comparator group or someone who is receiving services as normal or a different kind of services, and we have actual evidence to say that one is more likely to improve someone's mental health than the other. So we have actual evidence around that for that particular intervention.
Thanks for that, Alison. No, that's very interesting. In the interest of time, I'm going to move on now to Wietse, who's patiently been waiting in Denmark. And not only have you joined us all the way from there, but I know you're on holiday. So we really appreciate you agreeing to participate. Wietse, I wondered if you can tell us why the integration of mental health and psychosocial programming into humanitarian response is important. I mean, I know you feel it is, but can you tell us what the reasons are? And maybe what some of the opportunities for and challenges to such integration that practitioners should focus on? I had in mind, as I mentioned to you earlier, there's an article in the edition by Courtney Walton Mitchell and Leah James on some work they've done on integrating some of these approaches into disaster risk reduction programs in Haiti and Nepal. And so I wondered if you could comment on it from that perspective.
Yeah, thanks very much for the invitation and a great initiative. I'm really happy that mental health and psychosocial support get so much attention in the magazine. In terms of reasons for why I think integration is really important, I think the key reason really is that people generally not have one problem. I think people often have multiple types of problems at the same time. So if you are a refugee, you might have limited opportunities for making an income and having food on the table. At the same time, you may have psychological distress that is related to things that happened in the past. and there might be violence in the home. And we often see a combination of problems. People don't come with textbook humanitarian cluster-defined issues. So that I think is really a starting point for the need for integrated programs. At a very basic level, I think when you think about it a bit more, the need for integration becomes apparent when you think about how problems are interlinked, because one problem often leads to another, and so A leads to A. So people get stuck in downward spirals. You see across a range of issues. So the example that you mentioned is the one of the disaster preparedness. A disaster risk factor for mental health concerns, and those mental health concerns, it shows, in turn, are related to worse future disaster preparedness. That's the kind of stuff that programs need to address. Another example is that between intimate partner violence and mental health. Intimate partner violence is what was the focus of a project that R2HC funded in Tanzania with Congolese refugees. Intimate partner violence is the most common form of gender-based violence, also in humanitarian settings. And we know that intimate partner violence, or often a husband perpetrating violence on his wife, we know that that is a major risk factor for mental health concerns in the surroundings. And in turn, we know that being a victim of intimate partner violence and developing mental health problems as a result of that violence puts you at risk for further violence. So I think if we know that those kinds of interactions are happening, to me it almost doesn't make sense that we do have isolated programs. Don't get me wrong. Of course, there's going to be a need for vertical programs within the health sector or within the protection sector that address particular mental health concerns. But what we have seen in practice when it comes to mental disorders especially, is that once you treat people, but you don't address the negative if you treat people, you don't address the adversity in which people continue to live, they will be back. And we see that also, for example, in systematic reviews. We completed a Cochrane systematic review.
Vitsa, sorry to interrupt. You're breaking up. So I think yes, we can't really hear you.
After treatment.
Vitsa?
Oh, I'm sorry.
Yeah, no, I'm sorry. We can't. You're breaking up quite a lot. So I think I'm going to move on a bit, but we're going to have a question and answer session. We could hear some of what you said. You're basically talking about the the numerous problems that people have and the interrelationships between those problems and how one can exacerbate another, and how difficult it is really to focus on, or how inappropriate it would be just to try to focus on one of those in many cases, although there are arguments for vertical programs in some situations. But I'm sorry that we can't continue because it's difficult to hear. But let's see if during the question and answer session we can bring you in to respond to any questions that actually come up.